Nick, you can record now.
All right,
Okay,
Doc.
great.
All right, Doc. Thank you very much.
You're welcome. Yes, sir. Please,
Okay.
clinical features.
Okay, so with the clinical features, let's say you are taking the history. Why would you want to ask of miscarriages? That's one. And then two, why would you want to find out if the person uses a birth control pills? And then in ahead of investigation, just because of something that we'll be going through, you would want to check for UPT or pregnancy test for women who are less than 50 years.
Okay. All right. So that's an excellent question. It will take us back to what we discussed, I think 2 or 3 days ago. So if you have the slide, you can actually scroll up to risk factors, right? I sent some slides, so you can scroll up to risk factors, and it's
Okay,
there. So when you look at the risk factors, the reason why you need to, the first one is to ask about miscarriages. We know that most, apart from the fact that most miscarriages are due to chromosomal abnormalities, another cause of miscarriage or a major cause of miscarriages was blood clots formation. And that is why sometimes when you are seeing a patient who has recurrent miscarriages, you tend to put them on aspirin, okay? Aspirin is an antiplatelet, so it prevents blood clots, because we know that one other cause of miscarriage is a blood clot. Usually after you have the egg fusing with the sperm and all that, and then you have angiogenesis setting in the fetus. Sometimes a blood clot can develop, and once a blood clot develops, causing a poor perfusion to some parts of the fetus, then the fetus is going to die, and then you have a miscarriage. So as part of taking your history, if you ask, have you had any previous miscarriage, and the patient says yes, then the patient's risk of developing a clot goes high, because this patient has had history of miscarriages. And especially if you're able to prove that the miscarriages were due to a blood clot, then you can confidently say, okay, this patient has a high risk of forming a thrombus, which of course means that there's a possibility that the patient has a PE. Okay. The next thing, there's the pill you talked about. We realized that as part of the risk factors, estrogen therapy tends to increase the risk of blood clots formation. Okay. So most of these pills are oral combined oral contraceptive pills. They contain both estrogen. The estrogen levels are high, there's a risk there of you developing a clot. So that's the reason why you'd have to take a history of the pill. And also pregnancy, as I said, is also there. It's a risk factor, more commonly in the younger people. Once they are pregnant, there's a risk factor of you what's developing a blood clot. So you'd have to investigate what's your last menstrual period, all that. The whole idea behind that is to pick up a risk factor and a possible cause of the clot formation, so that we know how to go about our management. Okay.
Thank you very much.
You're welcome. Imagine you're managing a patient who you think has a DVT and she's pregnant, but because you failed to check, you missed the pregnancy, and then you are just managing. The patient will later sue you. Okay. So it's very, very key that we look at all that, especially when we are dealing with our females. So that's the reason.
Okay, sure. Thank you, sir.
You're welcome.
So someone asked of the RALE in the clinical features.
Yes. It's just like we are listening to those chest sounds, like those crepitations. You hear like some rough sound in the chest. I don't know if you guys have listened to an asthmatic chest before. Okay. Once you put your stethoscope there, you hear some sound, like maybe there's some fluid there, is moist. It's like it's scratching something. It's not like the classic crepitations that you hear, like something like a rubber or something. This one is like something dry scratching something. Okay. The rubbing effects, and possibly this is coming because of the pleura, and that's why I've been having the pleuritic chest pain. So you're hearing some rattling sound, rough, you're hearing some sound like that. So that is what we term as rales, okay? So it's not so smooth like the fine crepitations you hear. It's like something rough scratching over a surface, okay? So that is rales. Are we okay?
Yes, sir.
Yes, sir.
All right, okay. So, yes, so we go on. So after you've been able to assess all these clinical features, the next thing is what? Investigation, okay? So when you want to diagnose a patient who has a PE, the gold standard for diagnosis is what we call a CTPA, okay? So you can make that change on, it's on the slide. When you look at the last two things on the slide, you can see pulmonary angiography and you can see CT scan, okay? So usually we do the two of them together. So you're doing a CT scan and then you're going to introduce a dye into the patient's vascular system. And we expect that the dye is going to end up in the pulmonary vessels and is going to delineate. If there's any clots there, it will delineate it. So it's like blood from the veins will move to the right side of the heart and go to the pulmonary arteries and get into the lungs for oxygen, right? So if you introduce a dye into the veins, this dye would eventually end up at the right side of the heart, right? And then from the right side of the heart, it moves to the pulmonary arteries. So whilst it's moving, if there's a clot there, it will be unable to flow past it. So when you take your picture, you can see that the dye wasn't able to delineate all the vessels out. Then you can see that there's a blockage to the path of the dye, okay? Sometimes you do, and then it goes past it slightly. Some part of the lung doesn't have the dye. Then you can say that, all right, okay, the dye is going here. So it means blood vessels here are opened nicely, but then here there's a blockage. So it didn't really draw out the parting of the pulmonary vasculature well. That is what we call pulmonary angiography. So we usually do it together. We call it CTPA, CT pulmonary angiography. Okay, so that's like the gold standard. You do it and you can see that there is a thrombus sitting in the lung. Okay. Other things that you can do, of course, are usual full blood count. And usually when a patient has a PE, one thing we tend to see is that the white blood cell count increases, it goes up. So you see an elevated white blood cell count. Okay. We also talked about the fact that the oxygen and things might drop. So it's good to do ABGs, what we call arterial blood gases, to assess the partial pressures of oxygen in the blood, partial pressures of carbon dioxide in the blood. If partial pressures of oxygen is normal, then you know that the compromise is not so bad. If carbon dioxide partial pressures are very high, then it means that clearly the patient is getting hemodynamically unstable because you don't have enough oxygen in the blood. One other thing that is also a common investigation that we add is the D-dimer. So usually when you want to rule out a DVT or want to rule out a PE, you say go and do a D-dimer, okay? D-dimers are good, but they are not so specific. They won't tell you that the patient has a DVT or PE. They'll tell you that the patient is likely to have a DVT or PE, okay, because D-dimers can also go up in other medical conditions. Like when you have severe infections, your D-dimer can go up. When you have what we call DIC, disseminated intravascular coagulopathy, where your blood is clotting, basically, it gets to a point where the clotting factors all become diminished. So then you start bleeding, this thing goes up. The D-dimers also go up, okay? Usually when your blood begins to clot, we have what we call fibrin being produced, which is like from fibrinogen, clotting factor 1. The degradation of fibrin or the breakdown of fibrin is what will push your D-dimer up. So when we are talking about a DVT or a PE, as we said, we are talking about a clot, okay? And as part of blood clots, you would have fibrinogen coming in. So fibrin will be part of your red blood cell and your platelets to form the clot. When this clot starts breaking down in a way or it moves into circulation, it means that you are going to have what fibrin being broken down. And when this fibrin is broken down, D-dimers will go up. So that's the reason why D-dimers go up when you are dealing with anything clot related. Okay. So D-dimers are also very good. So if you have a patient with difficulty in breathing, pleuritic chest pain, there's no infection, D-dimer is high, you haven't done your CTPA, most likely this patient has a what? A PE. It won't hurt if you start managing whilst we go and get the CTPA done. You are in some village somewhere where you have access to anticoagulation. They rush the patient in. The patient has symptoms and you're able to pick up these signs we are talking about, maybe third and fourth heart sounds, rails. You pick all of them up by say, oh, I'm waiting. Go and go to Accra and go and do a CTPA and bring it back before I start giving you the anticoagulation, or I'm referring to Accra without starting anticoagulation. You've mismanaged the patient. Okay, if not for anything at all, you can start a prophylactic dose of the anticoagulation whilst you send the patient to do the gold standard test. And then once the patient does the gold standard test at the referral site, they can go on and then start a main treatment for the patient. Okay. So apart from your full blood count, arterial blood gases, D-dimer, CTPA, there's also the serum troponins that we can do. And when we're doing heart failure, I don't know if I mentioned troponins, but we'll be talking about troponins a lot when we discuss acute coronary syndrome. Hopefully next week, the last we'll present on acute coronary syndrome. Troponins are specific enzymes that are found there in the myocardium. Okay, so troponins will only come into circulation when you have a myocardial damage. So why would troponins be in circulation when you have a PE? Not always the case, but then in some cases you have to look out for troponins, because once you have a PE, the right side of the heart is also struggling to push blood into circulation. It's just like when you have severe hypertension and the left side of the heart is struggling to push blood into systemic circulation. When you have a PE, okay, the right side of the heart is struggling to push the blood from the right side of the heart into the pulmonary circulation because there's a pressure, there's something blocking it there. Okay, it's like having a stone in a pipe and trying to push water through. There's something blocking the right side of the heart from pushing. So while the right side of the heart struggles, it gets to a point where it stretches and it damages a bit and it releases troponins into circulation. So it's good to look out for troponins. When you find troponins, then it tells you that the P is that severe that is putting a strain on the right side of the heart. Okay. Another complication of a P is that it can cause right-sided heart failure. Okay, so once you have heart failure, of course, and it's this thing, you can see troponins there. So that's the reason why we look out for troponins. Then there's the chest X-ray, which basically would show what we call a Hampton's hump. Okay, what is Hampton's hump? When you after the lecture, try and Google Hampton's hump, and then you see when you take a chest X-ray of a patient who has a PE, you are going to see like a triangular shape on the X-ray. Okay, the base of the triangular shape will be close to the pleura, and then the apex or the pointed part of the triangle will be pointing towards the hilar of the lungs. Okay, the hilar is the part close to the heart, and then the pleura is the part away from the heart. So when you take a chest X-ray, you are going to see the Hampton's hump, and the Hampton's hump is basically telling you that that part where that triangular shape is has become what's infected. There's no oxygen going to that part. That is what we call a Hampton's hump. Okay, so when you take the X-ray, it's not all the cases that you are going to see this, but when you have a patient with this signs and you do an X-ray and you see a triangular shape with the base pointing towards the pleura, the apex facing where the hilum is. Most likely there's a lung infarction, and this could be coming from a PE, okay? Then another thing you can do is what we call the ECG. When you do the ECG, as part of the clinical features, the signs, we said the pulse will go up, right? So when you do the ECG, you are going to see tachycardia, pulse would be rapid, okay, on the ECG. So the next time we meet, I'll teach you how to calculate heart rate on the ECG. So remind me, even when we get to arrhythmias, we'll talk about that. So you see that the pulse will be what? High. Then there's a classic feature that you usually see in your MCQs, okay? So you see that a patient with PE would have the following on an ECG, then they'll give you some things. One other thing that you see is there's something we usually say S1, Q3, T3, okay? Basically what that means is that this S1, Q3, T3, what that means is that when you take your X-ray, you see that usually they've numbered it. I, AVR, AVL, AVF, you know. When you take the X-ray, the I there means lead 1, II means lead 2, II means lead 3, okay? So once you take the ECG, you look at the lead 1, you realize that there's an S wave there, okay? The S wave, as the name suggests, is part of the QRS complex. So usually when you take your ECG, there's a small wave, which is called a P wave. Then after that, there's a wave that goes up and peaks like a tent or a mountain, and then it comes down. That's the QRS complex. The beginning of the peak is what? Q. Then when it gets to the top of the peak is R. And when it comes down is what? S. Okay. So when you take the ECG, you are going to find, when you scroll down to slide 19, you realize that I've circled the S wave. Okay, so you're going to find an S wave, which is pronounced there. Okay, at the same time, you find what? A Q wave in what? Lead 3. So when you look at the lead, we have circled it. So the Q wave usually points down. Let's compare lead 2 to lead 3. When you look at the slide, okay, when you look at slide 19, look at lead 2, where they've written II, okay, you realize that the Q wave there doesn't come down so much like what the Q wave in lead 3. I don't know if you can see it. I mean, let me know if you can see it. Can you see what
Yes,
I'm trying to describe?
Yeah.
Good.
Yes.
Yes. So when you look at the lead 2, okay, and the lead 3, the part that I've circled, the Q wave that I've circled, look right above it on the lead 2. You realize that the Q part doesn't dip so much like what? The Q wave in lead 3. Okay. So that is what I mean by a Q wave in lead 3. It comes down, it dips down like that. Okay. And then when you look at the same lead 3, you're also going to have what? A T wave that is inverted. Ideally, the T wave is supposed to be looking like a mountain, but this time the T wave is looking like a plateau. Okay. So once you find S wave in lead 1, Q wave in lead 3, and then an inverted T wave in lead 3, classic, the patient has a PE. And that is what we call the McGinn-White sign, or the McGinn-White sign, which is S wave in lead 1, Q wave in lead 3, and an inverted T wave in lead 3. Okay. Are we okay with that before we go on?
Yes.
Great. This one, I know it might sound difficult in chewing, but when you read the slides and you take a look at it, it will just be stuck in your memory, okay? And ECGs are okay, but sometimes if you can't interpret them, you can't interpret the very difficult ones, nobody will stress you. If you can calculate heart rate on ECG and tell us what P wave is, QRS complex is, we don't have a problem. Because then when you are discussing the ECG with your boss, you can say, oh boss, I have this X-ray, but I can't see any P wave on it. But the QRS complex is very, very long, and your boss will say measure it. So now you are discussing, and your boss can make a diagnosis from that. Okay, or what I have this ECG, but then the T wave looks inverted, and your boss will ask you what lead, and you say, oh, lead 3, and you say, oh, all right, okay. And your boss will ask you, look at lead 1, can you find S wave? You say, oh yes, I can find it. Then it means it's going towards that. So sometimes you don't have to shoot. If you're able to keep it in your head, then you know. If you also know that PE can give you what changes on the ECG, as soon as you are suspecting a PE, you take your phone and then you just Google PE changes on ECG. This one will pop up. Then you quickly go and look at your ECG. That's how you practice. You don't have to chew everything, because you even forget. You are doing PDIX, you are doing ONG and all that. Okay. But if you know that there's something called ECG changes when you have PE, as soon as you have a case like that, you are just going to refer. When your exams is coming, you can take a look at your slide. For that short period, it will stay in your head, and then you can use it to write your exam. Okay.
Okay.
So don't stress yourself so much. Just try and have the picture in your head, and you can always go back and then refer. So basically, those are the investigations. All right, those are the investigations. Then complications. I said that apart from what we call sudden cardiac death, ECG is like the second cause of sudden death. Okay, P is the second cause of sudden death. Of course, you can have a P which will lead to sudden cardiac death. Okay, but the complications, you can say sudden death. It's fine. All right. Sometimes, because as we said, once you have a PN, the question the gentleman asked, your BP will start dropping. And once your BP starts dropping, systolic starts dropping below 90, then it means you are going into shock. Okay. So the other complication there is what? Is shock. Then you can have what we call pulseless electric activity. We'll be discussing this when we do cardiac arrest. Pulseless electric activity is a type of what? Cardiac arrest. What is it? Basically, as the name suggests, there's an electrical activity, but then when you touch the patient's carotid pulse, there's no pulse at all. Ideally, when you have an electrical activity in the heart, you expect that when you touch the carotid pulse, there will be pulse. Okay, what is electrical activity? Basically, before your heart contracts, you need your SA node, and then the SA node would basically generate. The SA node is a natural pacemaker, generates an electric impulse. It goes through to the AV node, then it goes through, you have right bundle, left bundle, all those things, the Purkinje fibers, it goes through, and then you can have the ventricles contracting. Okay, that means there's an electrical activity. In some cases, the ventricles fail to contract. And in so doing, when you touch the periphery, you don't feel any pulse at all. And that is what we call pulseless electrical activity. Okay. So, yes. So once we do cardiac arrest, I'll show you images of pulseless electrical activity. It has a normal ECG. ECG looks fine, but you touch the carotid pulse, nothing. Radial pulse, nothing. Okay. Patient has no pulse at all. That is what we call pulseless electrical activity. Okay. Another name for it is electromechanical dissociation, meaning you have an electrical activity, but then the mechanical activity of the heart to be able to pump is not there. So there's a dissociation between the electrical activity and the mechanical activity of the heart. Okay. So basically that's it. Then we have arrhythmias, okay, which we'll be talking about hopefully next week, within the week. Arrhythmias means that you have an abnormal heart rate and then heart rhythm. That's what an arrhythmia is. So ideally, you expect the heart to be regular, but sometimes the hearts will be irregular, and then you expect that the heart rate to be between 60 to 100, but then you check and this patient heart rate is like 140, or the patient heart rate is like 40. Okay, so this patient has an arrhythmia. Okay, so arrhythmia can either be a higher heart rate than normal, which is called tachyarrhythmia, or a lower heart rate than normal, which is called bradyarrhythmia. Okay, so when we get to arrhythmias, we'll talk about that. Then also, once the clot goes to stay there, you can have an infarction, and that is the triangular shape I was talking about, the Hampton's hump. So a lung infarction is a complication of a PE. Then you can have pleural effusion as well. You can have fluid collecting in the pleura of the lung, okay? And then the last one I put there is cor pulmonale. Cor pulmonale is basically heart failure that is secondary to what condition of the lung. So sometimes the heart can just fail on its own, secondary to maybe hypertension, ischemic heart disease, cardiomyopathy. But if the heart is failing because there's a problem with the lung, like in this case, you have a PE, and because you have a PE, as I said, the right side of the heart is unable to generate enough pressure to pump blood to pulmonary vasculature for oxygen and all that, then the right side of the heart fails, and then you have what we call a cor pulmonale. That is what cor pulmonale means, okay? So management, how do we manage our patients who have a PE? You've been able to diagnose the patient because you've picked the patient's history, you've picked signs, you've done investigations, ECG, everything is on point, CTPA comes, there's a clot sitting there. Now you have to manage your patient, okay? So the goal here in terms of management is to what? You want to get rid of the clots, one, and then you want to prevent other clots from forming, two. That is the goal, basically, okay? So whenever they ask you to manage a PE, at the back of your mind, okay, I have to get rid of the clot sitting in the lung, that is one. And two, I have to prevent other clots from what? From forming. Are we okay? Good. So how do we get rid of the clots there? We get rid of the clots by either giving some medication which will go and break down the clots or lyse the clots, and that is what we call what? Thrombolysis. Okay. So you give a medication that goes in and breaks the clot. So it's straightforward. We want to get rid of the clot. So let's give a medication that will go and break down the clot, and it's called what? Thrombolysis or thrombolysis. Okay. Now we don't want to form a clot, so let's give the patient what? A medication that will prevent the patient from forming excess clots, and that is what we call what? Anticoagulation. Basically, that is the basis of your management. Okay. The other way of getting rid of the clot is what we call embolectomy. So as the name suggests, lectomy means you are going to remove. So embolectomy means you are going to remove the embolus from the pulmonary vasculature. So if you have a good cardiovascular surgeon, cardiothoracic surgeon, they go and then they just do their things and then they do an embolectomy for the patient. Okay, sometimes the clot is so huge that it will take time. If you want to lyse, anticoagulate, it will take time. So once the patients come, you try to secure and get some good parameters, quickly transfer to the theater, do an embolectomy, and then send straight to the ICU for further monitoring. Okay. Sometimes even before the clots move into circulation, once you make a diagnosis of the clot. So this one is not to treat the clot or prevent the clot from forming. In this case, the clot has already formed. So you go and you put in a filter. It's called vena cava filters. That one too, the cardio people and the vascular surgeons do it. They look at where the clot is, and then above that, they put a filter. So even when the clot breaks, it can't go beyond the filter into circulation. The filter is like a mesh sort of. So they put it there, they secure it. So when the clot breaks, it just hits the filter and it can't go beyond and end up in the lung. So during this time, you are giving your anticoagulation, and then basically you get your bleeding back to normal. Are we okay? So that is what we call the vena cava filters. Okay. So that is like the basis of your management. Now the dose is what we've talked about when we're doing DVT. So let's say with the thrombolysis, you can always refer. Just know that if you are working with your boss you are not going to start the thrombolytic therapy. I mean, of course, unless after your program, you do other things and then you become maybe an emergency medicine specialist and all that. Or you find yourself in a position where your boss trusts you so much. But even before you institute a thrombolytic therapy, you have to talk to your boss first, because there are things that you'd have to satisfy before you start. If you have a patient who has a stroke, you don't know if the stroke is hemorrhagic or infarctive, you have no business starting thrombolytic therapy, because if the stroke is hemorrhagic, then it means when you give that, the patient is going to bleed more. At the same time, you even have no business starting anticoagulation on your own. You have to discuss with your boss. Okay, so there are lots of things that you look out for. If a patient has cancer, which is at risk of bleeding, you have to be cautious when you are starting your thrombolytic therapy, because this is linked to a complication of bleeding. Okay. To add to that, thrombolytic therapy is very essential because they did a study comparing two groups of people who had PE. The first group were managed using thrombolytic therapy and anticoagulation. The second group were just managed using only anticoagulation. Okay. And there was massive, almost 50% improvement in the group that they use both thrombolytic and anticoagulation therapy. So it means thrombolytic therapy is very essential. Once you rule out all the risk factors, it's good to institute thrombolytic therapy. And usually we say that there's a golden hour. If you want to start, it's good to start within 24 hours. Once it goes beyond that, when you start, it might not help so much, especially if you go beyond a week and you decide to start thrombolytic therapy. It usually doesn't help. So when you want to start, you should start thrombolytic therapy early. Okay. So an example of medication is streptokinase. I didn't put it there because now we are basically moving away from that because it tends to be erratic. When you give streptokinase, your patient might end up bleeding too much. Okay. So there are new medications. We call something recombinant tissue plasminogen activator. Okay. And plasminogen here, plasmin is an enzyme which is activated to break down blood clots. Okay. So when you activate the plasmin, you'll be able to lyse or break down blood clots. An example is altiplase, retiplase. If you see any medication with plase attached, it's likely to be a recombinant tissue plasminogen activator. Okay, so know that there's a medication you can give to break down the clots. Apart from the usual medication you can give to prevent the clots from forming, there's also a medication you can give to break down the clots. Okay. As for anticoagulation, you have to start and continue for at least 3 months. And as I said, if you scroll up to our slide in DVT where I gave the management, you realize that I said anticoagulation, you have heparin, okay, which can be either unfractionated or low molecular weight heparin, okay? And heparin would basically go and inhibit clotting factor 10, so it prevents you from forming clots in the first place, all right? So you give your heparin once you are treating according to the dose that I gave you in the slide. Okay, if you want to do unfractionated heparin, you can go ahead and do it. It's just that, as I said, once you do unfractionated heparin, you have to monitor the patients more. You have to do more APTT to be sure the patient is not over bleeding. The advantage heparin, unfractionated heparin has over low molecular weight heparin is that with unfractionated heparin, it works within a very short time, okay? So once you give unfractionated heparin, within a very short time, the effect wears off. So let's say you have a patient who you want to take to theater to do a thrombolectomy, you want to do an embolectomy or something for the patient, okay? You don't want the patient to be bleeding whilst you are doing the case. So if you go and give a low molecular weight heparin, which has a longer half-life, it means whilst in theater, the patient is still bleeding. But when you give unfractionated heparin, it works for a very short time and then the effect goes away. So that's like one advantage it has over the low molecular weight. But if you don't have to go and do any bleeding procedure on the patients, then you have to give low molecular weight because it's easier to give subcut, it's safer. You don't need to monitor the patient so much. Okay, and then I gave you examples that enoxaparin, trade name Clexane, and dalteparin, trade name Fragmin, with the doses over there. Okay. And I said that it's always good once you start, you also start your patient on what? Warfarin. Okay. You're starting your patient on warfarin, and this warfarin is essential because when you don't start the warfarin early, then basically the half-life of the time you need the warfarin to start working, you won't have it in circulation. So you always start warfarin with your heparin for about 3 to 5 days. By then, warfarin will be actively working. Then you would stop giving your heparin and continue your warfarin. Okay. I'm sure the link will drop soon. So let me just end it, and then I'll take questions, and then we can close. Okay.
All right, sir.
So please, yes, please join again in the next minute.
All right, sir.
Okay.